Thank you for joining us today, and I would now like to introduce Catherine Hunter with the Child and Family Services at the Department of Behavioral Health and Developmental Services to offer a welcome.
Thanks, Elaine. Good afternoon. I'm Catherine Hunter, the Behavioral Health Manager for the Office of Child and Family Services. We are excited to have you join us for our third installation of our school-based mental health Lunch and Learn series. Today's session, supporting students returning to school after psychiatric hospitalization, will focus on how mental health professionals can support students, families, and school personnel after a behavioral health hospitalization. By the end of this two-part training, you will be equipped with the foundational elements of an effective hospital-to-school transition protocol, as well as strategies for fostering improved communication and collaboration with youth, families, school staff, and behavioral health providers. We encourage your active participation with fellow participants in sharing your insights and asking questions. Once again, we extend a warm welcome and wish you a productive and rewarding experience. I will now turn it back to Elaine to introduce today's speaker.
Thank you, Catherine. It is my pleasure to introduce today's instructor, Dr. Laura Henderson Smith. Dr. Smith currently serves as an assistant professor in the School of Education and Human Development at the prestigious University of Virginia, as well as a licensed clinical psychologist. Her impressive academic journey includes a master's degree in counseling and mental health services from the University of Pennsylvania, along with a doctorate in clinical and social psychology from UVA. Dr. Smith's groundbreaking research takes a multifocal approach at enhancing youth well-being and reducing mental health disparities. Her work focuses on increasing the cultural and contextual relevance of school-based interventions, providing support to youth with significant mental health concerns within school settings, and strengthening the crucial connection between home and school, especially for marginalized and minoritized youth. With a rich background spanning schools, community mental health settings, and hospitals, Dr. Smith possesses a unique perspective on the challenges faced by youth returning to school after psychiatric hospitalization. Her dedication to improving the supports available for these particular students is nothing short of inspiring, and we are honored to have her guide us through this vital training session. Please join me in giving a warm welcome virtually to Dr. Laura Henderson Smith.
Thank you, Elaine, for that wonderful introduction. Gotta take some of those adjectives that you added in and put in my bio next year. So thank you, thank you. And thank you to all of you for being here today. I'm gonna get my slides up. All right, so as Elaine said, I'm Dr. Laura Henderson Smith, assistant professor and licensed clinical psychologist at the University of Virginia, and I'm excited to get to share with you all a bit about this work today. During my training, I did spent some time at the Commonwealth Center for Children and Adolescents, as well as at Inpatient Hospital up in Connecticut. I also spent lots of time working in schools. I was a second grade teacher before I went back to graduate school. And then I've also done some community mental health work as well. And so in working across psychiatric hospitals, community mental health, and schools, I began to see that there was really not a lot of support for kids who were returning to schools after a hospitalization. So it was something that I wanted to dig more into and something that I'm really passionate about and really grateful to be able to share with you all today about this work. So we'll do some introductions and we'll get into a background on youth mental health. We'll talk a bit about hospital to school transition and some important considerations. Talk about what that process looks like, and then how schools and districts can be prepared. And I've got some resources to share as well. But before we get into all of that, I would love to hear who's in the room. It's always helpful for me to know who I'm talking to so I can make sure that I'm tailoring the content to everyone who's here. So if possible, I'd love for everyone just to unmute when it's your turn. Tell me your name, your role and your organization as well. And then optional, what you're hoping to get out of this presentation. Or if you're just here listening, that's fine too. Since most cameras are off, I will just call names for you all to unmute, if that's okay. Please forgive me and correct me if I mispronounce a name. And so I just at the top of my screen, I've got Mary. Could you tell us your role in organization and what you hope to get out of this presentation?
Hello, my name is Mary Sheverton. I'm the coordinator of Student and Family Services for Pulaski County Public Schools. And I actually have a room full of counselors here with me because we weren't able to register that they were full. So I have 5 school counselors here with me. And then what am I hoping to get out of the presentation? Just more information about making sure that we have a good transition plan for our students when they are released from the hospital, that we are putting the correct supports in place to help them be successful at school and remain in the community.
Thank you so much, Mary. I'm so glad that you told me that you've got a room full of folks. Elaine, when we do the breakouts and Think, Care, Share, let's just let Mary connect with the folks in her room instead of assigning her to someone else, if that sounds good.
Thank you.
All right, Liz, I see you next.
Hey guys, I'm Liz Green. I'm the school-based clinician here at Dalton Intermediate School in Radford. I work at the CSB here in the New River Valley, and just hoping to get some new ideas. I've had lots of kids come in and out of the hospital while I've been working here, and always looking for new ideas to support them as they come back.
Thank you so much, Liz. All right, see Douglas next on my screen.
Hello, you can just call me Dougie. I'm a clinician and intensive care coordinator from RVHA. I hope to get more what therapeutic interventions we could put in place for our kids when they return to school, since we deal with a lot of kids get discharged from the hospital on a frequent basis.
Perfect. Thank you so much. And then I see a lovely face with the camera on, but for some reason I do not see a name on my screen. With some lovely fall decorations behind you and glasses. Sorry, I can't see your name for some reason.
That would be me. I'm Lori Gaskins. I'm the clinical coordinator at Bridges Children's Crisis Stabilization Unit with Western Tidewater Community Services Board. We're a step-down unit. Children come to us from acute placement, then to us, then we help to link them and help them integrate smoothly back into the community. So I'm looking at how to assist them with the easier school transition.
Perfect. Thank you so much, Lori. Chandra.
Good afternoon. My name is LaShondra Everett. I'm the program manager for New Horizons Youth Case Management with Prince William Community Services. Primarily here because I think over time we kind of gather bits and pieces and ways that we can help youth. But it would be great to kind of hear some maybe best practices and learn a little bit more from others on what they're doing.
Great, thank you so much. Sheree?
I'm sorry, you said Sheree, correct?
Yeah.
Awesome. Yes, my name is Sheree Thompson. I'm a child and family case manager with RBHA. I do work with adolescents on a regular basis, and we do see hospitalizations. From time to time, they haven't been as frequent specifically for me as they have been in the past, but I'm always open to learning new information, especially with the transition back to school and into their community.
Thank you so much. Bethany.
Yes, hello. I'm Bethany Thornton. I'm a clinical supervisor at RBHA in the Child and Family Unit. And I also manage our hospital community liaison. And so we work really closely with any kid who's hospitalized and getting them set up with all the best services. So I'm just, here to learn, here to take in information today to take back to my team.
Awesome. Thank you.
All right.
So I think I was at is it Kiara?
Kiara, yes. Hi, my name is Kiara Robinson. I'm the lead clinician for the Community Crisis and Mobile Crisis Response and Community Stay program. So we work with children and adults. I'm here because we often are a step down for children as they leave the hospital, going back into community. So I want to learn a lot of best practices for integrating back into the school setting.
Perfect. Thank you so much, Kiera. And two more. We got Kimberly.
Hello, I'm Kimberly Glover. I'm a child and family case manager with RBHA, and I'm here just to learn more information and ideas on how to transition our kids back to school after hospitalization.
Perfect. Thank you so much for being here. And is it Daniela?
Yes, it is. Hi, everyone. I'm Daniela Taylor. I'm with RBHA. I'm one of the clinical supervisors for the therapeutic day treatment program. And so while we don't see too many hospitalizations with our elementary youth, it does occur with our middle and high school youth. And so I just want to get some information to share with my staff for a successful transition.
Perfect. Thank you so much. I'm so glad to have all of you here and just to be able to know more about your backgrounds as we get into the presentation. This next quick little icebreaker is just a good visual way for us to all see who's in the room. So Elaine showed you that raise hand feature. And so I would like you, I'm going to read some prompts to you, and I just want you to raise your hand if that applies to you. I'm going to have mine on gallery view here so I can see. And if you all want to see who else is in the room, feel free to switch to the gallery view. So raise your hand if you work in a school as part of your job. Not if you're primarily based in a school, but if any of your role ends up being in school. All right, let's see this one. All right. Raise. All right, you can put your hands down now. Oh, a couple hands here. It's like maybe some people are figuring out the raise hand feature. It's down in the bottom under reactions. If you click on it, you can see the hands. Or just give us any reaction. Any reaction will be fine. Doesn't have to be raising the hands necessarily. Raise your hand if you are a school district administrator. I think maybe Mary was. Yep. All right. Raise your hand if you work at a hospital or if you collaborate with a hospital in your role. Okay. Raise your hand if you work in the community in some capacity. Probably everybody. All right. Raise your hand if you support elementary school students in your role. Raise your hand if you support middle school students in your role. Okay. Raise your hand if you support high school students in your role. Okay. Raise your hand if you have supported a student returning to school after a behavioral health or psychiatric hospitalization this school year. Quite a few already. All right. And raise your hand if you are confident in your abilities to support students returning to school after a psychiatric hospitalization. And no judgment. We're all here to learn more. And lastly, easy one, I expect all the hands. Raise your hand if you want to learn more about how to support students returning to school after psychiatric hospitalization. I love this celebration, LaShandra. Thank you. Feel your excitement. All right, so thank you all for introducing yourselves and for engaging in that activity. Like I said, it's just really helpful for me to kind of tailor the presentation to the folks who are in the room. I'm often talking to rooms that are primarily school folks, and so I'll be thinking a bit more about those of you who work in the community and CSBs and other organizations as I present. So getting started, we are going to do a quick background on youth mental health overall and in Virginia, things that most of you probably know already. Nearly 20% of school-aged youth experience some type of mental health issue.
And although 20% do have those experiences, a much smaller number experience psychiatric hospitalization, but that number is growing. And in particular, of that smaller number of students who experience a psychiatric hospitalization, a large number of them are readmitted after discharge. So it's really important to think about the role of school and other community organizations and caregivers, and making sure that these youth have the supports in place that they need to be successful after hospitalization. In Virginia, we've actually dropped from 21st to 48th in terms of how we are able to support youth mental health. There's also been a significant increase in emergency department visits due to self-harm. There's also been a shift in demographics for these youth as well. So the majority of self-harm emergency department visits are now girls, and the majority of suicides are still boys. That's been pretty common, but it's been common that the majority of completed suicides are boys. But we are seeing an increase in the number of girls that are making attempts as well. There's also been a particular increase in Black boys. So really seeing some shifting demographics here. Aside from those who visit the ED or may experience a hospitalization, about 13% of high school youth in Virginia reported seriously contemplating or attempting suicide in the past year. This is data from 2021 that was collected during 2019-2020. So we're hoping that there's been an improvement in some of these metrics. I think a lot of this was from during the COVID period when students were often at home and experiencing loneliness and an increase in depression and anxiety. So hopefully things aren't as dismal as they were when this data came out. However, we do know that there continues to be a mental health crisis in this country and in this state that requires significant attention. These are just some numbers that show increases in emergency department visits and hospitalizations. So in 2016, there were about 6,500 emergency department visits in Virginia for youth who were experiencing self-harm. And then in 2021, that number doubled to over 14,000. Somewhat of an increase in hospitalizations, but not nearly as significant as those who required emergency department visits. Just want to point out that those numbers don't include children under 9 who do occasionally have hospitalizations for these same things, but not nearly as often. And then this also doesn't include youth who visit the emergency department or hospital due to psychosis, out of control behaviors, or any other thing like that. These also don't include the youth who die by suicide. So we're going to be talking a lot about the hospital to school transition, but these kids who go to the emergency department and then transition right back to school are also a growing population of concern these days. So some of you may be familiar with the governor's Right Help Right Now plan that kind of talks about the need for improved behavioral health care in this state. This here is a continuum of behavioral health care in Virginia, where they identify where kind of pre-crisis intervention services take place, where crisis care takes place, and then where post-crisis recovery and support take place. And so you can see that schools and colleges are identified in the pre-crisis intervention services space, and I've circled that there in orange. Although it may look like the school buildings under crisis care and post-crisis recovery and support go with this model, I actually put them there. So I thought it was really interesting and great that they identified schools as a site of pre-crisis prevention services. But all of us here know that schools also often are providing crisis care. A lot of students who are referred to the emergency department and subsequently hospitalized are referred from school. And then when we're talking about transition after a hospitalization or emergency department visit, we know that school is also stepping in there for post-crisis recovery and support. So want to highlight that school is really a place where all of student mental health needs are getting met. where we have really qualified school mental health professionals who can help bridge care, who can help families to think about services needed beyond school, and can just be supportive people to provide psychoeducation to students and families after a hospitalization. Do want to note that we obviously do not expect schools to provide all of the mental health services that students need. But given that students spend a lot of time in school, it can be really nice if school staff and school personnel are trained up on mental health literacy and are aware of community referrals and can do some triaging and crisis support in that school space. But obviously, we expect kids with these significant mental health needs to also be receiving services in their communities. All right, so now we're going to get into hospital to school transition. So schools are so important for transition. We know that they can help ease the kind of stress that students are experiencing after a hospitalization, or they can increase stress after a hospitalization when students are coming back and they aren't sure what to say to their teachers and peers about where they've been, or they're stressed out about all of the work that they've missed, or maybe they're not acutely suicidal anymore, but they're still feeling pretty depressed. So school is a great place for students to be able to return to with folks who are trained to be able to support their needs. Some students, depending on the community, may go to a step-down facility or step-down program or intensive outpatient or partial hospitalization programming, but many go right back to school. And that is the recommendation, that soon after discharge, there is a reentry meeting and that child gets right back to school to really start to return to normalcy and get back into their usual routines. So as we know, schools are often involved in the referral process. They can be involved in preparing youth for a hospitalization. If they're making the referral, letting them know what to expect when you get to the emergency department and what the options are. Maybe you'll be discharged back home and connected with a community provider. Maybe you'll be hospitalized, but there's definitely an education piece that can be provided on the front end. Schools can also provide support during a hospitalization. This varies. There are some districts that say, like, once they go to the hospital, they're the hospital's responsibility, and then we pick back up as soon as they're discharged. There are other schools that are very involved and communicative. Sometimes it's providing schoolwork if it's going to be more than just a couple of days. And sometimes some folks from school have the capacity to be able to visit as well. So it's always helpful to have some type of support during the hospitalization, and that often varies across district. All right, so just a few reasons to highlight why we want to focus on schools. Youth who are hospitalized often felt disengaged and disconnected at school prior to hospitalization. So the return can be a really nice time to help get them re-engaged and to think about how to make them feel more connected. Students spend a significant amount of time each day at school where they're trained and supportive adults who can support their mental health and overall well-being, in addition to their loving caregivers and their community providers. And then also minoritized and marginalized youth, as well as those from low income backgrounds and those receiving public insurance, are more likely to only receive mental health services at school. Again, it's not ideal. These kids need community services as well, but it may be particularly important to make sure that we have supports in place for that group of students, or those groups of students. And so as we talk about reentry, we'll mostly be talking about short-term hospitalizations today, and a bit about emergency department visits as well, since that's a large group of students. But I do want to point out that there are a number of other reasons that you might follow some of the same reentry practices. So long-term hospitalization, residential stay, juvenile detention, medical illness, a lot of the things that we'll be talking about in terms of transition are applicable regardless of where a student is transitioning back to school from. So just want to make a few statements about emergency department visits. So these often entail, or not often, these entail a psychiatric evaluation and crisis stabilization, and then discharge planning. And so that planning either results in transfer to an inpatient unit, hold in the emergency department until a bed is available or discharge home. And when they go home, they come right back to school. And this is a really tricky group to support because often these are the kids who have spent a significant amount of time with the counselor. The counselor sends them to the emergency department because they feel that their needs are beyond what can be met at school. And then the hospital doesn't think that they're an imminent risk to themselves or others, and then they send them right back to school the next day. So it's a really tricky group that we don't always think about when we're discussing transition, but all of the things that we will discuss today can definitely be applied to this group as well. For kids who are hospitalized, they go through all of the same stuff that I just highlighted in terms of emergency department visits, but during that hospitalization, there may also be initiation of medication, or maybe a student's already taking medicine that's not quite working, so they're modifying it or managing it. They're also getting some treatment in the hospital, so they should be receiving individual therapy, group therapies. There may be some family therapies as well, and then some educational programming. And so I always think it's really important to highlight that in the emergency department, they're not getting any treatment. So they're often just coming right back to school after some stabilization and then discharge. And in terms of the educational programming, that really varies. For kids who are just in for a couple of days, they may not feel up to doing their schoolwork. There are some kids who want to do their schoolwork to help them kind of feel more of a sense of normalcy, but wouldn't always expect the kids to have completed all of their work by the time they have come back from a hospitalization. I'm sure none of you all would expect that either. All right. So now I've got a quick poll for us that you should be able to see on the screen. You can use the QR code here, or you can click this in on the web, pollev.com/Laura Henderson 836. And if you can just take a minute to answer these two questions, the first one being how many students do you typically transition back to school after hospitalization each school year? And then the second question being how many students do you typically transition back to school after an emergency department visit?
Dr. Smith, we do not see the poll.
Okay, no wonder no one has responded. Let's share screen 2 again. Can you see it now?
It says 0 surveys completed, 2 surveys underway.
There we go. Thank you. All right. You should be able to see it now. I'm gonna click that so I can see. All right, 2 underway. So for folks who still need, I'm going to go back here. You can either scan the QR code up here, or you can type this pollev.com/Laura Henderson with no N 836 into your phone or computer. Just a few more seconds and then. Okay. So it looks like it really runs the gamut of how many youth you all are supporting. With some having smaller numbers, 0 to 5, and others really up there with the 16 plus. I imagine that one of those might be the person who works with the hospital liaison, but really runs the gamut here. And then just like the national and state level data is saying with that increase in emergency department visits, looks like that is a really common area in terms of supporting these youth as they are returning to school. So, thank you. Let me get my slides back up. Share. Slideshow on current slide. All right. So now I'm just going to highlight some problems and needs in hospital to school transition. This is a really busy visual that I always hesitate on sharing because there's so much stuff here. But I think that it's a nice, complex visual that really speaks to the complexity of the challenges in hospital to school transition. So in the middle, it highlights some of the problems and needs that youth have. And then it kind of spans out to their families, the school, individually. And then as it spans out even more, it looks at some of the challenges across systems. So the family in the hospital, the family in the school in the hospital. And then it goes out even broader and looks at some of the bigger issues that impact hospital to school transition, like stigma, insurance issues, and things like that. But it also shows that kind of spanning all of these different arenas, the child, the family, the school, the hospital, that communication, coordination, and collaboration are key. I don't think it's an accident that communication comes first. These transitions are so difficult when the school has not been able to be in contact with someone from the hospital, or when there's not a hospital liaison from the CSB who is helping to kind of bridge the connection between home and school. So for the youth, they're often dealing with new and persisting problems. Maybe they have a new symptom and some ongoing depression. Maybe they are dealing with side effects from a new medication that they started. Often there's a lack of follow-up. Sometimes, you know, that in our communities, there's a long wait list for care, or maybe caregivers are having a hard time getting them to the appointment that was set up for them. So those are some of the challenges there. Often families are overwhelmed and stressed with the hospitalization, and I always say that school can step in, because when the family's in the hospital, they're stressed out, they're anxious, they're worried. And even the most awesome emergency department clinicians and folks in the hospital can have all of this information about their child's issue. But when that parent is in that high space of stress, they're not taking that all in. So school can be a nice place for when they come back and they're re-entering to kind of reiterate some of the psychoeducation around best supporting their youth's mental health. Some challenges kind of in that outer band across systems, just highlight a few. Often families struggle with parental involvement. I know that when I was working at the Commonwealth Center, we were getting kids from all over the state. So it was impossible for some parents to be able to come in for a family session because they couldn't physically get there. Or maybe we could offer a family session online, but some families were in jobs where they weren't able to attend a family session during the hours that we were working at the hospital. So definitely some challenges there. Also, there are challenges seeing the family in the hospital and the school in the hospital in terms of discharge information. Schools often talk about how helpful it would be to have some information from the hospitalization to know how to best support the child when they return. And often families don't feel comfortable sharing that information from the hospitalization, or they may not sign a release of information. So that really leaves a void in terms of what the school might need to know to best support that student's needs as they return. So just highlighting a few of those there, but there are just a number of different challenges that occur across these systems. And so now Elaine's going to put us in pairs, and I think Mary can just talk with the counselors in her office. But I wanted you guys to take a moment to discuss in pairs about what might be missing from here. If nothing's missing, what do you encounter most in your work? And what are some ways to overcome those problems or challenges, or to meet the need that you encounter most? And we can drop these questions probably in the chat for you also once you are with your pairs. And so I want you to take about 5 minutes, and then we'll come back together and share out. All right. So thank you all for engaging in that activity. I'm wondering if there might be a couple pairs who want to share any of these, if you know something missing, if there's something you encounter, or what kind of problem solving you came up with. maybe if we can hear from two folks and then we'll move on.
It's Doug. I'll go first. So
Thank you.
talk to one, yeah, of course. Talk to one of my colleagues, Sheree from RBHA, and I was telling her that with something because I work with, they've been going to the hospital at home, not and they haven't been engaging any self-harm behaviors at the school. It's mostly at home. So one of the challenges I'm facing, me personally, on a professional level, is like getting in contact with the school to see what services we could put in place for that youth. Especially if there's not a day treatment there. So like make sure we get the medications in order and how to figure the medications, what safety plan we can put in place. And it's hard to coordinate with RPS sometimes. So and so the transition is never easy for the kids to go back to school immediately. So sometimes we have them work the talent from home before they go back to school or something to get perfect homebound. But yeah.
Thank you. Yeah, that is definitely a challenging when students are displaying issues at home that they're not displaying at school. And some schools are more willing to kind of step in and be supportive of that, whereas others may say like, they're doing fine here. We're not sure what to tell you. So that's a really big challenge. I appreciate you sharing that kind of conundrum that you're often ending up in. Thank you.
Yeah.
Hey, so this is Mary Cheverton with the school system. And one thing that we run into a lot of times is that it kind of goes along with what they were just saying, is that things happen outside of the school and then it's not shared with us. Like we are unsure that we don't even know sometimes that a student's been hospitalized if the parent doesn't share it, or if the hospital doesn't notify us. And then also for us, we are down in Southwest Virginia and just a lack of resources. When their students are hospitalized, sometimes they'll go to Roanoke or Salem, but often it's across the state. And so it's multiple, if this child is ECO'd, and law enforcement take them, then they have a hard time getting back to us. If they're in Newport News, our families sometimes don't have the resources to get the child back. So it's just, we struggle a lot. And then families sitting in the emergency room for 5 days, and then they're sent home with a recommendation for services. But that's hard too. That's hard to get that started. And if they're not involved with CSB, we don't always hear from a discharge planner on what needs to happen.
Yeah, those are all very real concerns. And I know this stuff that I present on is often like from the research and the evidence base, and like these are the best practices, and sometimes it's really, really hard stuff to implement. So I appreciate you sharing those kind of real world concerns that you all experience. And towards the end, we'll have some time for some troubleshooting and problem solving together. So I may be able to offer some suggestions, and there may be other people on here that can share some of the things that have worked for them as well. So thank you, Mary and Dougie. All right, so now we're gonna roll on along as we get ready to talk more about the hospital to school transition process. I just want to highlight a few important considerations. I was trying to mix up considerations and hospitalization and make a new word. And so first, as we've already seen at multiple points in this presentation, most students will not be hospitalized. Most will visit the emergency department and go right back home and right back to school. Like Mary was just saying, some will go to the emergency department. And it's one of the reasons I highlighted those slides earlier about distinctions between the emergency department and hospitalization. For those kids who spend 5 days in the emergency department, even though they were there for that long, they're not getting any treatment. They're just getting crisis stabilization services, and then they're waiting for a bed. And sometimes after that 5 days, they will have stabilized and they no longer need a bed, and then they're discharged. Other times they may still need a bed and then they may be transferred, but that's been 5 whole days of them not getting any services or treatment in place. But overall, most students won't be hospitalized. They'll spend time in the emergency department and will be discharged. Also, like Mary was just saying, a lot of times school may not be aware of a hospitalization. So this is kind of highlights the importance of teacher-student relationships and kind of noticing when something's been up with the student or something seems a little bit off, to try to kind of figure out what may have been going on or where a student may have been. And if you suspect that a student may have been hospitalized, then looping in a school counselor or an administrator or someone that can help. Then also there may be cultural differences. And I think that this kind of links back to schools not being aware. Some families, some communities still have a lot of stigma attached to mental health, and they may not want school to be involved or to know about that. And again, having those strong teacher-student relationships or some having that strong relationship, also just building, making the school welcoming, inviting place, positive school climate can help to address some of those cultural differences and make families feel more comfortable. Also, we're talking a lot about tier 3 here, and these kids who have these significant mental health concerns, but the tier 1 interventions are always so important to hopefully help with prevention, but also if you're not preventing the hospitalization, for a student to come back into a school where there is tier 1 social emotional learning or some tier 1 mental health literacy or other things in place. One second. Excuse me. Oh, all right, nothing like a coughing fit in the middle of a Zoom presentation. All right. Some other considerations for emergency department referrals. 30 to 40% of these referrals come from school. And ED clinicians often consider a large number of these school referrals to be inappropriate. And reading about this, I don't think they're inappropriate. It's just that these students have significant mental health concerns that kind of go beyond the threshold of what school can meet, but then fall below the needs of what doctors perceive as their job in the hospital. But then we know that we have all these wait lists and services that aren't put in place. So these kids are kind of falling in limbo. School mental health professionals can perform a good risk assessment to make sure the students who go to the ED actually need to be there. And then it can be great if schools identify community-based alternatives to the ED as well. So excuse me, y'all. I'm okay. All right, and then a few considerations for these kids who are discharged home. This group has been overlooked. They likely still require some type of intervention, even if they don't require a hospitalization. And many of the practices related to hospital to school transition are transferable to these ED kids as well. So now we're going to talk big picture about the school reentry process. This part of the talk is intentionally big picture, and then in 2 weeks, when we come back together for the second part of this presentation, we'll get into the nitty gritty. This is embarrassing, sorry. I had COVID a few weeks ago. It's not that, just all the talking. All right, so in a couple weeks when we come back together, we'll kind of get into the nitty gritty and some specific strategies for implementing these things that we're about to talk about. So in terms of hospital to school reentry practices, one study found that 42% of schools had no reentry plan or protocol at all. Of those that did, only 32% had formal or written protocols, and a quarter had informal protocols. Rural districts were less likely to have these plans in place. And in some districts, the school level policies or protocols were at the district level. There was about 2/3 of the districts, and then in a third, they had some school level policies in place. So just curious if your school district or organization has a formal or informal plan. So let me pull up the poll. I'm gonna put it on this page first so that you can use the QR code again if you need to, or type it in. I'll leave it there for just a few seconds. All right, I'll give it about 5 more seconds, and I'm going to move to the next slide where we can see responses. All right. Okay, so from what I see here so far, you all are in the right place today to get some insight into these protocols. So I imagine that this might be what a lot of you are here for. All right, let me get the slides back up. Current slide. All right, you see the slides again? All right, I'm going to trust that you see them and move on along. All right, so this is a 9-step framework for successful school reintegration after psychiatric hospitalization. I'm going to talk about a few tweaks to this, but I will give kind of a overall run through of what this plan means. First thing I'm going to do is come to this slide. So the first step is addressing school reintegration as soon as possible. So this means as soon as you're sending a child to the emergency department, or as soon as you find out that a child has been hospitalized, you're starting to think about what it is that that student will need to be successful upon their return. The folks who identified this model have that as step 1. As you can see here, I love to kind of highlight things in orange that I think are important. So they have step 4 as ensuring leadership in the coordination of a reentry plan or reintegration plan. I actually think that ensuring leadership should come first. So some schools have a reentry team that might consist of an administrator, the school counselor, maybe a case manager if the student already has an IEP, but it's really important to have this leadership in place prior to a hospitalization or emergency department visit so that you're able to proactively meet the student's needs instead of reactively scrambling and responding. So first step is really identifying who are the members of that leadership team. And if they have training or if they need additional training to be able to effectively serve in that role. After you've got your leadership team in place, that's when you start to think about school reintegration as soon as possible. Step 2, or I guess would be step 3 in my modified version, is evaluating needs during the hospitalization. So while a child is hospitalized, ideally you'll be able to connect with their caregiver to get a release of information signed so that you can connect with folks from the hospital to be able to determine what's going on and what they might need upon their return to school. Next is offering academic and psychosocial support during hospitalization. Again, this varies. I know that in some small communities where there's a hospital right there, school counselor, administrator, teacher, other people may have the capacity or want to go visit. In other cases, that may not be possible, especially if a child's hospitalized all the way across the state somewhere. But generally, students knowing that folks from school really care about them or are concerned during the hospitalization, not just for the student, the family as well, can really help bridge things for when they return. Again, this is all dependent upon knowing that the student was hospitalized, and a lot of the time we don't have that information. Also, academics can vary. I know that there are some places like the Commonwealth Center where they have a school on site and students are actually unenrolled from their home school and enrolled at the Commonwealth School for their stay there. But there are other places where there just may be a teacher who's there to help students to complete the work that's been assigned to them from their home school. So that can vary. Always say in terms of the academic and psychosocial support, it's really about meeting the student and family where they are. There are some kids who are not in any shape to be able to do their academic work during the hospitalization, but there are others who may appreciate having that to keep their mind off of things. So really have to fill things out there. Gonna skip over step 4 because I already moved that up to the beginning. Step 5 here is evaluating needs in anticipation of the student's return to school. So I know Dougie had mentioned some students go homebound. And so as you evaluate needs, you're thinking about if the student perhaps needs homebound services, or if they need a modified school day, or maybe it's a student who was hospitalized due to an eating disorder. Maybe they don't need to eat lunch in the cafeteria, that's a trigger. So they need to be able to eat somewhere else. So This is to really think about what you might need to do differently, what you might need to put in place for that student upon their return. Step 6 is developing a school reintegration plan. I have a model of that I forgot to share with you, Elaine, but I can share with her to get it shared with you all. And then I'll share some another one as well that you can access online. But a school reintegration plan really looks specifically at what the student needs in terms of academics when they return to school, what they need in terms of social support when they return to school. And it highlights who is going to help meet those needs. It's not just coming up with the makeup plan, but it's student has this makeup plan and so is going to check in with them about it, or the student needs this type of support and they're going to have a check-in, check-out every day with Miss so-and-so. So it's really coming up with clear, actionable items and assigning people to make sure that the students' needs are met in those areas. And then steps 7, 8, and 9 are really just about thinking about the social environment, the student and their family, and what additional supports might be needed beyond this school reintegration plan. Got ahead of myself here. So just I mentioned some about the leadership team, and I know I mentioned administrator and counselor, but other folks that may be involved include case managers, teachers, school psychologists, school nurse, school social worker, particularly for students who are starting medication or medication's been modified. The involvement of a school nurse can be very, very helpful. Also mention that when you're evaluating needs for return, there may be different options for the students. Some districts may have specialized school reentry programs, although I don't think I'm familiar with any of those around here in Charlottesville at this point right now. But there are some model programs around the country if anyone's interested in learning more about that and has funds for something of that nature. And so when you're developing that school reintegration plan, part of that is so that you can hold a school reentry meeting. These meetings are held before a student returns to school. Ideally, every now and then we have a kid who comes back to school, and that's when we first find out that they were hospitalized. But ideally, this meeting will take place before the student returns to class, and it should include designated school officials from that leadership team, as well as parents or guardians, and the child for at least a portion of the meeting. It's always helpful if someone from the hospital can attend or call in, but that doesn't always happen. The plan should be clearly documented, and it's not just a matter of coming up with the reintegration plan or having the meeting, but it's just as important to maintain ongoing communication and to follow up to make sure that that plan is being implemented, and to really continuously progress monitor and reevaluate the student success and their needs. I highlighted this already. And so what's not on here is that follow-up and progress monitoring piece that I think is often really challenging because we just get so carried away on all of the other things that there are to do in a school or in our community organization, and there are all these other kids who need support, and maybe we're following up with this kid, but then we've got a couple other kids who have recently returned from the hospital or emergency department visit as well. But that follow-up and progress monitoring is so important, particularly for these kids who are hospitalized, and we know there's a 30 to 40% readmission rate. This can really help us to kind of see when things aren't going as planned with the reintegration plan, and when we can readjust, offer different supports, or make community referrals to try to make sure that the students' needs are being met so that they hopefully can have their needs met at school and in the community without another visit to the hospital or emergency department. All right, so one more poll here. I can get to it. 3, last poll. So again, scan or type that in if you need to. I'll leave it there for a few seconds. Maybe about 5 more seconds. See what the responses are. All right, so it looks like most places are somewhat prepared. Maybe some that are more prepared. Good. All right, thank you all. All right, so this part is truly going to focus more on school and district planning. But I do think that there are considerations for our community providers as well, especially as you partner with schools, since I know that you do so much of that work. And in our part 2 of this, I will make sure that some of those strategies that we discuss are applicable across settings as well. So as we talk about this, we are mostly talking about our tier 3 students who have required a hospitalization and are now identified as in need of intensive mental health services. However, there are still tier 1 and tier 2 things that we can do to support all students as it relates to this topic. So around tier 1, just training and professional development for all staff to increase mental health literacy is so important. Also tier 1 programs that can support overall student well-being. Most schools now have some type of tier 1 social emotional learning programming in place, and that can be so helpful for supporting student mental health as well. Also at tier 1 is where we want to think about developing formal transition protocols for students returning to school. We don't want to wait until we've got students at tier 3 and start scrambling, but tier 1 is really where we're doing all the planning and putting things in place. Along those same lines, resource mapping is really important here. And we'll talk more about resource mapping in a couple weeks, but this is where in your school or in your district, you're able to identify community providers or partners so that when a family comes to you or you identify a child who's got some mental health needs, but they don't quite meet the threshold for needing an emergency department visit, you can make a referral that hopefully will be able to meet the student's needs and that they'll be able to take them in. So really having a number of different resources that you can share with families is important. Also at tier 1, mental health screening can be great, universal mental health screening, so that we can get an idea about students who might need tier 2 or tier 3 support. And I know universal mental health screening is kind of recommended best practice, but also schools report being kind of in a double bind when doing universal mental health screening and identifying students who are in need of services that cannot be met in the school or in the community, given the mental health crisis that we're in. So I want to acknowledge that it's research recommended best practice, and then also in reality can be really difficult to know what to do with that information when you can't meet those needs. All right, so at tier 1, we talked about just kind of overall mental health literacy for all adults in the school building. Tier 2 is when you're getting into targeted training and professional development for school mental health professionals, administrators, and others. So something like this, where it's not just broad mental health literacy, but now we are specifically talking about how to meet the needs of these students with significant mental health concerns. At tier 2, it moves from kind of the whole school socio-emotional learning curricula to programs or small groups for students identified to be at risk for mental health concerns. You also may do some suicide screening at this point. So we're typically not doing suicide screening at tier 1, but if a teacher is concerned about a student, or if one student says that their friend was making some statements, this is where screening comes in, and having these trained school mental health professionals to do the screening is so important. And then from tier 1, we did some resource mapping, talked about being aware of what's available in the community. And then at tier 2 is when you're making those referrals if needed. In terms of targeted training and professional development, I just want to highlight a couple. These are also on the handout that Elaine shared in the chat. But the Birch Project, there's a link to it on the handout, is a group up in Massachusetts, and they have some work around supporting hospital to school transition. They have some modules on YouTube that can be helpful. They also have a hospital to school transition protocol that if you go to their website, you can just email and ask them for it. I don't know why they don't just have it posted there, but you email them, ask for it, and they will share it with you freely. I, full disclosure, don't use their protocol in its entirety. It's really long, and I don't find it to be something that most folks in schools have time to kind of go through all 24 pages or whatever it is. But I do think that it's a helpful guide for kind of seeing like overall best practice, and there may be things from it that you can pull from your practice in schools or in the community. Also, Maryland Behavioral Health has some online modules around supporting students returning to school. And then I'll have a training here at UVA that's forthcoming in the fall. That will be a module, and then we'll also provide some virtual reality practice for engaging with students and families around this topic. But all of these, the Birch Project and the Maryland Behavioral Health modules are freely available online, and the training coming out of here at UVA will also be freely available as well. At tier 3, this is where we start thinking about students getting individual counseling interventions, safety planning for kids who have identified suicidal ideation or maybe engaging in self-harm or other things. Tier 3 might be when you do have to make that ED referral, done the resource mapping and community referrals, and those didn't quite work out. This is when you implement that emergency department or hospital to school transition protocol that you developed at tier 1. Other strategies might include like check-in, check-out with the student who is returning to school after a hospitalization. And so in the next workshop in a couple weeks, we'll really dig into all of these. I'll have some examples of safety plans, some examples of re-entry plans, some sample interventions that you can do. But today is really kind of the big picture to start thinking about your school or organization strategy for re-entry and kind of assessing where you are in the process. So we're going to take about the next 10 minutes in a breakout room to discuss what your school district organization is currently doing at tier 1, tier 2, or tier 3 to prevent and respond to student psychiatric and behavioral health hospitalizations. What are the strengths and areas for growth? What are next steps or improvement? What are 2 to 3 strategies you can implement? And what might be barriers to implementation? Obviously, that's a lot to discuss in 10 minutes. So maybe pick 1 or 2 of these questions that really stand out to you or that seem really impactful for thinking about where your district or organization might go in terms of hospital emergency department to school transition. So Elaine is going to put us in small groups. We'll come back together at 1:20 and we'll have some time to share out and for Q&A before we wrap up at 1:30.
All right, I am opening the rooms.
Everybody's back? All right. So I would love to hear maybe from 2 people about the conversations that you all had in your room. And then we will wrap up and have some time for Q&A. So I'd love to hear what maybe some strengths and areas for growth are, or maybe barriers that you want some support in problem solving, or anything you'd like to share that we'll discuss.
In our group, we were just talking about with Richmond Public Schools, how there's no consistency, there's a lack of, and while some schools may be having reentry meetings, many schools aren't. You might have some schools who can be a model school for the other schools in the district, but pretty much each administrator is kind of doing their own thing with their building, because even like with one of the case managers sharing, she had never even heard of a school having a reentry meeting.
Wow.
I have some staff, at least one that I know of, and when I previously was a clinician in a dual role as a case manager, I participated in a reentry meeting, but I do recognize that RPS probably, it's not consistent across the board.
Yeah, and some of the research I showed earlier says that some schools have kind of school level plans and other districts have district level plans, but definitely if things are coming from the district, it can be much more uniform and helpful. And you kind of, as someone who works in the community and partners in different schools, it can be much easier when you know what to expect with similar schools, with the same schools across the district. So that definitely is a challenge. Thank you for sharing, Daniela. So maybe one more person who wants to share out a highlight from their discussion.
So this is Mary again with the school system. We do have a district form or template that we encourage all of our counselors and administrators to use to help guide the meetings. We were talking about some of the barriers though. The student just shows up. Like we don't know that they're being discharged and the parent hasn't told us, and the parent is just very eager to get the student back to the school day and like to their normal routine. And so sometimes a student just pops up and we, we're unaware that they're coming in, they ride the bus into school. And so we're kind of caught off guard. And then lack of communication from placements. We don't know. We really, count on the parents to tell us, and it goes back to the stigma. I was working with one yesterday. The parent called and said that they're in a facility, but when I called to try to find out, a little bit more, the parent said, "Well, I can't tell you where they are. Like we've been told not to tell." So we're like, "Okay, that's fine, but let us know if we want to help support." And so I think it goes back to just the communication. And if there's not a release on file, the hospital can't talk to us. And so there's just a lot of different barriers. I think everybody wants success for the student. It's just how do we make sure that we're all working together?
Agreed. And it's so challenging because there are things that you can do to be supportive of any student who's returning. But if you know a bit more about the details or their specific needs, then you can really tailor a plan to them. And that'll be more effective than just a generic plan. So that communication piece is so challenging and something we can talk more about on the webinar in a couple more weeks. Thank you, Mary. All right, we've got 5 minutes for Q&A. So actually, I think I got one more slide and then we'll go into that. Just wanted to share a few resources. I already mentioned the Birch Project training and resources, and then the Maryland Behavioral Health online modules that are linked on the handout. Also, the schoolreentry.org website was developed by Marissa Maricini, a school psychologist down at UNC Chapel Hill. And it has some recommendations for hospitals, schools, and families, and a lot of resources. It's specific to students with suicidal ideation and after suicide attempts, but again, has some helpful information there. So I'm now happy to answer any questions that you all might have. Or any feedback. If there's something that I didn't touch on today that you absolutely want to make sure that I touch on in 2 weeks, just any Q&A, feedback, discussion would be great.
Yeah, I have a question. I'm just kind of curious, or maybe you could touch on this next time too. I feel like the CSB or case manager's role is kind of sometimes a bridge between a hospital and a school, and just any ways that you can see that partnership being more successful, or any kind of ideas of how we as mental health professionals can support the school in kind of bridging some of those, just the transition back to school as well.
For sure. I think that the folks at the CSB can be really helpful with that communication piece. It's like you said, it can really be a bridge. And I think that often CSBs have better relationships, not necessarily better relationships with the hospitals, but work more closely with the hospitals. And so we're able to perhaps get information from the hospital that can be shared with the school, obviously with consent from caregivers and everything. But I think that the CSB worker can be really helpful in terms of bridging the communication and helping to ensure that schools have the information that they need from the hospitalization. And I think that in some cases, there are the parents that don't want the school to know, and there's nothing that we can do about that. But in other cases, there are parents who are like trying their best to communicate what happened during the hospitalization, and they were stressed, or they don't understand, or they were in crisis. So the CSB worker can be super helpful in terms of kind of helping translate and be another person to provide information to the school about what was going on in the hospitalization. Also, just from a practical standpoint, I think that the CSB worker has more contact with the folks at the hospital, or and may have better relationships, or has talked to this case manager at the hospital more than maybe the school counselor has. So it can sometimes just be easier for you to connect with the folks at the hospital than the folks at school can, in between teaching their classes and teaching a SEL lesson and lunch duty and all of those things. So I think that you really hit the nail on the head in terms of being a bridge, and particularly bridging communication.
Cool, thank you.
You're welcome. Time for one more question. Well, if there are no more questions, then so we can wrap up. Feel free to reach out to me via email if you have a question that you didn't want to ask on here in the large group.